Next gland, suprarenal gland. You will see in many books it's given as adrenal. It's the same thing. A better name is really suprarenal because it's lying on top of the kidneys. Kidneys are called renes or renal. So since it lies on top, suprarenal is a better term. It has two regions, the suprarenal gland. It has an outer cortex and an inner medulla. The cortex is divided into these three zones. Each zone produces a different hormone. Collectively, all of these hormones have the word corticoids associated with this because these are steroid hormones. So the outermost zone, which is just near the capsule, this zone is called zona glomerulosa. It's called glomerulosa because the cells are arranged as, the cells kind of arrange themselves as in a circular ball-like fashion and resemble the glomerulus of the kidney. So this area is called zona glomerulosa. It produces hormones which are responsible for electrolyte balance, so that, therefore, which are minerals. So it produces what are known as mineralocorticoids, and we'll see that there's one of them in particular that we'll talk about. The second zone is called zona fasciculata. The word fascicle means bundles. So fasciculata, the cells are arranged in a linear bundle-like fashion like this. So these are all the cells. So notice how the cells are arranged here in a bundle-like fashion. Notice here how they are circular. This produces hormones called glucocorticoids, which are to do with glucose metabolism. So they'll raise, amongst one of their actions, they raise blood sugar levels. The third zone is called zona reticularis. Reticular means like a network. So the cells are kind of arranged in a network-like fashion. A lot of spaces in between. And these produce sex hormones, or also what are known as gonadocorticoids. So if you look at this picture, you can see that between the zona, this is the cortex. The zona fasciculata is the largest of the zones. So, you know, if we were to divide it into four parts, approximately 1/4 is the glomerulosa, then is the fasciculata, it's about 2/4, and then the reticularis 1/4, and, you know, roughly divide that. And then innermost is the medulla, which is entirely different, and we'll see what the medulla produces. So let's look at the suprarenal hormones. Zona glomerulosa produces mineralocorticoids, so to do with electrolyte balance. The main hormone that we talk about is this hormone called aldosterone. Its function is to reabsorb sodium from the kidney. So it causes sodium absorption. Actually, the word should be reabsorption is a better word. When we do the because absorption actually occurs in the digestive system. And then it goes into the bloodstream. So when it comes into the kidneys absorb it all over again. So that's why we call it reabsorption in the kidneys, okay? So it causes sodium reabsorption in the kidneys, and sodium is osmotically active. So when sodium is absorbed, water is absorbed along with it. So it's reabsorbs this sodium from the kidney, along with that water is also reabsorbed, and then that is thrown into the bloodstream. Okay, so what will it do? It will raise your blood pressure and blood volume. Because if you push more water into the bloodstream along with sodium, your blood volume will increase. The more blood volume you have, your blood pressure will increase, right? And when it takes in sodium, it takes in one positive charge, it removes potassium. So potassium is excreted and passed out in the urine. So it exchanges potassium for the sodium reabsorption. The main stimulus for release of this aldosterone is something known as the renin-angiotensin mechanism. When we do the urinary system, we'll talk a little bit more about it. Renin is a hormone which is produced by the kidney. There are arterioles in the kidneys which produce renin. So if someone's blood pressure and blood volume has fallen, right, the blood that's being filtered by the kidney arterioles realize that the blood pressure and blood volume are low. They immediately secrete this hormone called renin. Renin goes in a loop and will cause secretion of another hormone called angiotensin. And then angiotensin releases aldosterone. And what will aldosterone do? It will absorb sodium. With that, it will absorb water. So it will bring your blood pressure and blood volume back to normal. Okay? The other is that if there are low levels of sodium and very high levels of potassium, that also will stimulate the release of aldosterone. There is this hormone, ANP. Does anyone remember what ANP stands for? We mentioned it quite a few times. What's that? No. Atrial, yes. Neurotic. Peptide, yes. Natriuretic. Okay? Natriuretic. Natri is from the word natrium, which is sodium. Remember, sodium, the symbol is Na, that comes from natrium. Okay? So natriuretic. What does the word natriuretic tell you? Yes, that means sodium is pushed out in the urine, right? So more sodium goes in the urine means, remember I said sodium was osmotically active. So if you removed sodium and pushed it in the urine, it is going to drag water with it. So can you see that someone in who there are increased levels of ANP, what will they do? They'll pass more urine, so their blood volume and blood pressure will come down. So do you see how aldosterone becomes an antagonist of atrial natriuretic peptide? Okay? So let's take a look at
aldosterone promotes the reabsorption of sodium and water by acting on the kidney, and this concentrates the urine and raises both blood pressure and blood volume. Reabsorption of sodium and water into the bloodstream by direct action on the kidney. As shown in this table, angiotensin II has a variety of other effects due to its stimulation of AT1 receptors. For example, it can introduce more fluid into the body by stimulating the hypothalamus of the brain.
Okay, I just want to go back just so that you understand.
Hypothalamus of the brain.
So here, this is the kidney tubule. Right next to the kidney tubule, you have blood vessels. So if these are the cells of the kidney tubule and this is the lumen of the tubule, here is where sodium and water are present in the lumen of the tube. So it passes from the lumen into the cells of the kidney tubule. From the cells of the kidney tubule, it passes through this interstitial space and into the bloodstream. So that's how it increases your blood volume and blood pressure, because the sodium and water in the end has to go into the bloodstream. Everything that you absorb or reabsorb finally goes into the bloodstream. Okay? So in case of ANP, what ANP will do is it will remove sodium and water from the blood through the kidney tubules, go into the urine, and it will pass out. Have you followed? It's just the reverse direction. Yes. And let's look at renin-angiotensin mechanism.
My lower back pain,
horrible, so excruciating.
it was almost unbearable.
Renin-angiotensin-aldosterone system. The renin-angiotensin-aldosterone system is a classic endocrine system that helps to regulate long-term blood pressure and extracellular volume in the body. The system begins with the release of angiotensinogen into circulation by the liver. This may be in response to low blood pressure and adverse changes in sodium concentrations. An enzyme, renin, is secreted which cleaves angiotensinogen to form the inactive decapeptide angiotensin 1. Further transformation of angiotensin is carried out by angiotensin-converting enzyme, or ACE. This is predominantly found in the pulmonary circulation. However, ACE is also produced in the vascular endothelium of many tissues, including the kidney, adrenal gland, brain, and heart. The angiotensin-converting enzyme converts the inactive precursor angiotensin-1 into the vasoactive peptide angiotensin-2. In addition, alternative pathways exist that do not rely on either renin or ACE. In non-renin pathways, enzymes like tonin and cathepsin D
You can ignore
release
this part.
angiotensin-1 from angiotensinogen and tissue plasminogen activator, or TPA, and can make angiotensin-2 directly from angiotensinogen. This bypasses the midway production of angiotensin-1. Enzymes like kinase can form angiotensin-2 from angiotensin-1 via an ACE-independent pathway. Angiotensin-converting enzyme also degrades bradykinin, which is required for synthesis of a major vasodilator, nitric oxide. Angiotensin-2 binds AT1 receptors expressed on the surface of vascular endothelium and impairs nitric oxide synthesis as well. Reduced bioavailability of nitric oxide combined with the stimulation of AT1 receptors on smooth muscle cells causes vasoconstriction. In addition to a vasoconstriction effect, stimulation of AT1 receptor causes the adrenal glands to release the hormone aldosterone, resulting in sodium retention. Combined with vasoconstriction, this increases blood pressure. In the final stages of RAS, the kidney reduces the production of renin. Most of the known
So I know it had a lot of hormones and other pathways which you didn't need to know, but from that what I did want you to take away is that angiotensin does cause release of aldosterone, but what was its other action that was important? Action of angiotensin mentioned in the video. What was the other action? Very good. It decreases nitric oxide levels. Nitric oxide is a vasodilator. What was another effect of angiotensin? Think of the word angiotensin. It increased blood pressure because remember it showed you it directly constricted the blood vessels. Angiotensin, tensin means tensor. Tensor means to constrict. Angio is blood vessels. So angiotensin has a direct action on the blood vessels. It causes constriction of the blood vessels, right? And here, when it causes release of aldosterone, and what does aldosterone do? It causes sodium reabsorption. With sodium, there's water, so your blood pressure and blood volume increase. But angiotensin by itself also raises blood pressure because it constricts the blood vessels, raises peripheral resistance. If you were looking at that video carefully, there was something mentioned as ACE, right? This is angiotensin converting enzyme. I don't want you to write this, just understand that. How many of you here have grandparents or parents who take blood pressure medication? Go and ask them what blood pressure medication they are taking. Sometimes many of them will be taking something which is known as ACE inhibitor. The reason you take these people because they have high blood pressure. If you allow their normal levels of angiotensin to be produced, imagine that could raise your blood pressure even more because it has the capacity to constrict blood vessels. When you take something as ACE inhibitor, what will happen? It will prevent the conversion of angiotensinogen to angiotensin 1 and then, that 1 to 2. So if angiotensin levels are decreased, your blood vessels will not be constricted, plus you will produce nitric oxide. Remember that bradykinin which is needed for nitric oxide, so your blood vessels will dilate and so your blood pressure will come down. This is the reason why they give them ACE inhibitors. Not everybody is given ACE inhibitors. In some situations, when needed, they do that, okay? So I really wanted you to see from this, to apply it to your, everyday knowledge. So when somebody tells you, I have high blood pressure, find out what they are taking and see if you can understand why they're taking those. You had a question?
I get migraines, and I know they're caused by dilation of blood vessels in the brain. So I'm on a blood pressure medication for it, and I'm just wondering how it necessarily works.
Migraines are a bit different. When your blood vessels dilate, and in migraines, it depends on what there are different types of migraines. What happens, it also stretches the dura, and the nerve endings get stimulated in that case, and the stimulation of those nerve endings causes the migraine. In your case, there could be other reasons why you've been given the blood pressure medication. It couldn't be just, simple just migraine. So there may be other things that you might be having, which is why they're giving you that. Okay. Let's look at the next region, which is zona fasciculata. This produces glucocorticoids, of which cortisol is the main hormone that we will talk about. This region, zona fasciculata, is mainly under that loop, corticotropic releasing hormone from the hypothalamus, which acts on the anterior pituitary, causing ACTH or adrenocorticotropic hormone to be produced. And this adrenocorticotropic hormone acts mainly on the zona fasciculata. It does act on the zona glomerulosa, but not as much. Here the main part is the renin-angiotensin mechanism. So let's look at some of the actions of zona fasciculata. These glucocorticoids are produced in times of stress. So this is for long-term stress. This is when this is produced. Because in times of stress, you want your blood pressure to be normal, you want your blood volume to be normal, and you want your blood sugar levels to be adequate so that your tissues are provided with enough glucose to metabolize. So you can see this maintains blood volume and blood pressure. It does this by making the receptors in the blood vessels more sensitive to epinephrine and norepinephrine, which is why when people are collapsed, if they have lost a lot of blood, and they come into the emergency, as you're kind of trying to replace the lost fluid, you also give them a shot of steroid glucocorticoids so that you make the blood vessels more sensitive to epinephrine and norepinephrine, which will constrict the blood vessels and raise your blood pressure and blood volume. It maintains blood sugar levels, so it keeps your blood sugar levels normal. It does this by producing glucose from non-carbohydrate sources. See, glucose is a carbohydrate, right? It's a simple sugar. So when you have something like starch, which is a complex sugar, and that starch is broken down, it will finally end up as glucose. But you can produce glucose from amino acids, which is proteins, and from fats. So these are non-carbohydrates. When you produce glucose from non-carbohydrate sources, that is known as gluconeogenesis. If you think of the word, gluco is for glucose, genesis is to make, neo is new. So glucose made from new sources, and the new sources are proteins and fats, okay? So it causes gluconeogenesis. What it does is it breaks down amino acids when the body needs that, and those amino acids are able to produce glucose. Same with fat. So it breaks down fats and causes glucose to be produced. It is under this feedback loop, this one, but when there is acute stress, then that feedback loop is lost and it overrides that.
I was just wondering, I've had issues with blood sugar levels during pregnancy, and I've been taking DHA, amino acids, and omega-3s. Could that be affecting my sugar levels? Like, if I
No.
take too much of the amino acids, because normally the amino acids will wake me up, but I'm just feeling really tired. And it's that and the probiotics and everything that I've added are amino acids.
The amount of amino acids that you're probably taking are not so much that they're going to make and pregnancy always results in fatigue, especially the first trimester and the last trimester. So it could be that. Yeah. Yeah, you're probably not taking enough to, do that.
I've never heard of making sugar out of amino acids.
That's
the person.
Yeah, no, the amount, this is done in the body where a lot more is broken down. Okay? It breaks down proteins, and as I said, and another very important thing that this glucocorticoids have is they have an anti-immune and an anti-inflammatory effect. So it has a good and a bad part to it. You may have all, at some point or the other, if you have a rash on your body, if you have some sort of an eczema or something, you always will put a steroid ointment on that, right? So it has that, and it prevents inflammation. So, you know, somebody has swelling in the joints, for example, constant swelling, they get steroid shots within the joint. It prevents inflammation because it prevents macrophages coming to that site, and macrophages cause a lot of inflammation. But the downside to it is that if it prevents this inflammation, which is a normal protective part of the body, this has an anti-immune effect then. So people who have this tend to fall prey to a lot more infections. You may have noticed when you are under stress, those of you who are prone to acne tend to get more acne during that time. You also get more prone to infections. You know, during the time of your exams, everybody tells you, take your vitamins, be careful, because, you know, since there's stress, a lot of cortisol is being produced at that time, and it differs from person to person. You do tend to fall prey to infections more during that time than you would otherwise, okay? So there is the anti-inflammatory property is good, but it also has its downside. That means you could be more prone to that. And putting an ointment on your skin is not going to have such a severe anti-immune, even though it's absorbed from the skin. But if you take steroid shots, or you're taking steroid tablets, which, you know, you take on a regular basis, then you do get more prone to infection. So one has to be a little bit careful. So let's look at aldosterone secretion. So here are the primary regulators. If there's decreased blood volume or blood pressure, that is sensed by the kidney, which produces renin. That goes to, you know, produce angiotensin gets converted to angiotensin 1, and then finally to angiotensin 2. And this angiotensin 2 goes to the zona glomerulosa, where it produces aldosterone, which targets the kidney tubules. Increased sodium absorption, with sodium absorption water and potassium is removed, so your blood volume and blood pressure are raised. You can see here, okay. If there is an increased potassium in the blood, you want to get rid of that. That also stimulates the zona glomerulosa, does the same thing. Other factors that could happen is under stress, corticotropic releasing hormone is produced, which goes to the pituitary, produces ACTH. Remember, I said that ACTH also acts on the zona glomerulosa, not to that much of an effect as this, because this is a primary regulator, and this goes and acts on that, and you have the same thing. If, on the other hand, your blood pressure and blood volume are very high, like someone has congestive heart failure or something like that, then atrial natriuretic peptide is formed, which does its job, and it also depresses the zona glomerulosa. So you can see that this is an antagonist. So at this time, you have seen two sets of hormones which are directly antagonistic to each other. One is the aldosterone ANP, and the other one was parathyroid hormone and calcitonin. Okay, so you must kind of learn of these hormones in pairs. Okay, let's look at this. Aldosterone acts in a manner somewhat similar to which hormone? So think of all the hormones you have done so far. Parathormone. Okay. I don't know why everybody chose parathormone. The correct answer is ADH. What does parathormone do? Parathormone raises serum calcium. Aldosterone doesn't raise serum calcium. It has nothing to do with calcium at all, okay? What does aldosterone do? It reabsorbs sodium. With sodium, it reabsorbs water, and the end result is increase in blood volume and blood pressure. Okay? What does ADH do? It only causes reabsorption of water, which ends up raising your blood volume and hence blood pressure. Do you see that? So it is somewhat similar to ADH. because both raise your blood volume and blood pressure. Oxytocin just acts on the uterus and on the mammary gland and then generates those feelings of affection. So not that. Doesn't do that. And remember, the other name for ADH was vasopressin. Causes constriction of the blood vessels too. So therefore it causes blood increase in blood volume and blood pressure. Parathormone, as I said, it acts on the calcium. It raises serum calcium. So very different from aldosterone. And thyroxine is general tissues. Its main action is to increase your basal metabolic rate. Okay? So aldosterone and ADH act similarly. The difference being that ADH causes only water reabsorption and a lot of it. Aldosterone primary is sodium, but with sodium water also goes in, so both end up raising blood pressure and blood volume. Okay, what's the main stimulus for aldosterone secretion? Main stimulus. Renin-angiotensin mechanism. The main stimulus is the renin-angiotensin mechanism. These two are secondary. The main stimulus is the renin-angiotensin mechanism. Okay. This everybody should get right. I think I've been saying this for a while. A and P, yes, very good. A and P, none of these. A and P is the main antagonist. Okay, let's look at the next zone, which is zona reticularis, produces gonadocorticoids, testosterone and estrogen. In fact, in females after menopause, the zona reticularis is the only area which is producing your hormones, estrogen. These are not under control of that ACTH-CRH loop. They control onset of puberty, and when we do the reproductive system, we look at what are the hormones of what are the functions of testosterone and estrogen at that time. I mean, testosterone mainly for male reproductive and estrogen for the female reproductive. So we look at that at that time. Let's look at the medulla. This produces an entirely different set of hormones which are collectively called catecholamines. They are epinephrine and norepinephrine, and the medulla is connected to the sympathetic nervous system. Because from the spinal cord, remember we had the nervous control of release of hormones. From the spinal cord, in the T1 to L2 segments of the spinal cord, you have cells present which belong to the sympathetic nervous system. From here, the nerves come out and they go to the medulla of the suprarenal gland, and then the cells in the medulla secrete epinephrine and norepinephrine. So they're directly under control of the sympathetic nervous system. Epinephrine and norepinephrine, the actions are very similar to whatever the sympathetic nervous system does. So you should remember this from ANP1. What does it do? Sympathetic nervous system increases heart rate, causes vasoconstriction, so therefore increases the blood pressure. It also increases by causing gluconeogenesis, causing breakdown of glycogen. It raises blood glucose levels because you want more glucose so that your cells can metabolize, produce energy, and allow you to do whatever actions you have to. It causes dilation of the bronchi and the bronchioles, relaxes the smooth muscle there so that you can breathe better, increase metabolism so that you can produce more ATP, and it is basically a fight response that is produced. This medulla acts more when we have short-term stress, because this can act really fast. So for short-term stress is where the medulla is acting. For long-term stress, that's where the zona fasciculata, where the cortisol, the glucocorticoids are released. So let's review the adrenal gland.
Hi, in this video I'm going to talk about adrenal gland function. So let's start off by talking about where the adrenal glands are located. Here are the kidneys, and they're situated in the abdomen. This is the left side and the right side. And notice the left is a little higher than the right. Now on the left kidney and the right kidney are these two little hats, and they're called the adrenal glands. Now let's have a look at the structure of an adrenal gland. The adrenal gland is made up of 3 layers of cortex and then an inner medullary layer. The most outer layer is the zona glomerulosa. The next layer is the zona fasciculata. The third layer is the zona reticularis. And then the adrenal medulla is situated in the center. These 3 layers make up the adrenal cortex. Now I want to have a closer look at a section through the adrenal gland. So here are those 4 layers. I'll just label them G, F, R, and M. Now they each produce different hormones. Now the zona glomerulosa produces aldosterone. The fasciculata produces cortisol. The reticularis produces sex steroids. And the medulla produces epinephrine and norepinephrine, or adrenaline and noradrenaline. That's the same thing. Now, epinephrine and norepinephrine are signals of a fight or flight response. The sex steroids are important for reproduction. Cortisol is a stress signal, and aldosterone is important in water retention. Now let's have a look at their control. The medullary release is controlled very simply by sympathetic activation. So it's controlled neurally. The rest are controlled hormonally. ACTH, or adrenocorticotropic hormone, releases cortisol from the fasciculata, but it also has a minor effect on the reticularis in releasing sex steroids. ACTH is released from the pituitary. Angiotensin 2 causes the release of aldosterone, and it's part of the renin-angiotensin-aldosterone pathway. And that's an overview of adrenal gland function.
For more free tutorials,
So that was a really good review of the whole gland and what everything, which is neurally controlled, which is hormonally controlled, and which hormones are responsible for that. So let's look at, we've done some hormones and which ones which act on blood pressure and vasoconstriction. So which of these would increase blood pressure by causing vasoconstriction? So you should know some of these other activities or actions of these hormones. So which of these causes vasoconstriction and which one does not? So here you have to look at the one that does not. Okay, so let's look. Epinephrine causes vasoconstriction. Remember, it's a hormone of the sympathetic nervous system, causes vasoconstriction, increases peripheral resistance. That's how it increases blood pressure. Angiotensin. Remember, I told you angio meaning blood vessel, tensin meaning tensor or pressor, causes constriction. So does that, raises blood pressure. ADH. The other name for ADH was vasopressin. So just like angio or vaso, both to do with blood vessels, pressor or tensor meaning constriction. A and P, it removes fluid, it removes sodium and water. It actually decreases blood pressure. Just by that you should have understood. It has no action on blood vessels. It does not constrict blood vessels, so blood vessels remain dilated. So A and P was the right answer for this. Okay? So this is the stress response that I was talking about. So you can see the short-term stress, and this is prolonged stress that you see over here. So let's take a look at this video first.
The stress response. In stressful situations, the body switches on its autonomic nervous system and neurobiological processes in an attempt to maintain homeostasis. The body is prepared for its reaction to stress. In the brain, the hypothalamus is connected to the pituitary gland. The hypothalamus, stimulated by the sympathetic nervous system, releases the hormone corticotrophin-releasing factor, CRF. The CRF activates the pituitary gland to release the adrenocorticotropic hormone, ACTH. This in turn alerts the adrenal glands. The adrenal glands are located on top of each kidney. The ACTH from the pituitary gland stimulates the adrenal cortex to release cortisol. At the same time, neurons in the hypothalamus signal the medulla to release epinephrine, adrenaline, and norepinephrine, noradrenaline. These hormones then push the body into hyperalertness.
So if you look at this, in short-term stress, it's epinephrine and norepinephrine which is released, but in prolonged stress, it's the cortisol which is released. Why do you think that epinephrine and norepinephrine are released first in short-term stress? Yes, it's the fight or flight, but there's a reason why that is.
Fast-acting, short-lived hormones. They get around the body really quick, but they don't last as long as cortisol would, so they're not going to have a long-term effect. It's an immediate response.
It is an immediate response, but I was looking for another reason why it is immediate, based on the method of secretion. Yeah.
Is that because the receptors makes the receptors in the blood vessels more sensitive?
No.
The difference between fear and prolonged personal hate.
No. The reason is the nervous system is quick acting. Endocrine system takes a while to act, but it lasts longer. What is the medulla under control of? Neural response, right? The cortex is under the hormonal control. So this takes a while to act. It takes a while for that step, one hormone and then another one and then goes to release. Nervous impulses, like I remember I said right at the beginning, the nervous system and endocrine system have similarities but differences. One difference is that this is like a air mail and this is like real slow, snail mail, okay? So because nervous impulses come really fast, so this comes from the sympathetic neurons through the nervous impulses and comes to the medulla, quickly releases epinephrine and norepinephrine, puts your body into that quick standby alert mode, and that's why this is a short-term response. This one takes a while, but it lasts much longer. So when you have long-term stress, then you can see that this will kind of last longer, but just take a little while. So when you are under stress, in the beginning it'll be this which will be produced. If the stress continues, then you'll have cortisol which will be produced. And you can see both of them kind of cause similar actions. So this will increase your heart rate, your blood pressure will increase, bronchioles dilate, glucose will be produced. This will again increase your blood pressure and blood volume. Again, you produce glucose by gluconeogenesis, but the immune system at this point is suppressed because the anti-inflammatory action kind of becomes more than normal. Okay? Let's stop here. So let's exercise our brains a little bit. I don't know how many of you watch Brain Games on National Geographic, right? You watch that? This was given to kids. This is a school bus, an American school bus, okay? It was given to kids. Can you believe a vast majority of the kids got it right? Vast majority of the adults got it wrong. I was one of them who got it wrong. So, but now, of course, I know the answer. Just shows like how kids think and how we think, it's so different. So tell me, which direction do you think the school bus is traveling? Is it going, so use your clickers, is it going left or is it going right? Okay, not bad. It is going left. Okay, it's a school bus, so, and we drive on the right side of the road, so the door is that side, right? Right, so it's going to travel this way. Okay? Yeah. See, yeah, I know. It is so simple. It's such a simple answer. I know, we kind of tend to overthink things. Kids do it. So next time I'll have another thing to show you and maybe y'all can tell me. Again, kids got that one right too. Adults didn't. So it's strange. Okay, let's now look at some clinical conditions to do with the suprarenal gland. So we have one disease which is called Addison's disease, which is hyposecretion of both mineralocorticoids and glucocorticoids. And in these people, because there is, apart from a lot of other symptoms that they may have, and always remember that when you have a disease, it's not necessary that you have to have all of those symptoms, okay? One could be predominant, a couple could be present, others you may not find at all, so you don't kind of get tied into that. But here you can understand these people suffer from dehydration and hypotension, because mineralocorticoids are lacking, which means that sodium is not being reabsorbed and hence water is not being reabsorbed with it. So a lot of sodium passes out of the body, drags water with it. So they keep losing a lot of sodium and water, which leads to dehydration. And because you lose a lot of water means blood volume also comes down. So these people have hypotension. They may even go into what is called Addisonian crisis sometimes when, they become too dehydrated. A loss of glucocorticoids or less glucocorticoids means they would be prone, again, immune response would be depressed, they would be prone to, problems, so on, okay? One of the main features in this is because of the mineralocorticoids not being present, so they have dehydration and hypotension. Second condition is something known as Cushing's syndrome or Cushing's disease, where there is hypersecretion of just glucocorticoids, cortisol. This could be either there is some problem directly in the adrenal cortex, or it could be where there is hypersecretion, a tumor, let's say, in the adrenal cortex, in the fasciculator zone, which is causing increased production of glucocorticoids. Or it could be a pituitary tumor, which is causing increased ACTH production, which in turn will stimulate the fasciculator, so the end result will be increased glucocorticoids. So these people have what is called, and what is the function of glucocorticoids, right? Is they have increased blood glucose levels, because glucocorticoids tend to increase your blood glucose. So these people could actually have symptoms very similar to diabetes. So that's really known as steroid diabetes. So someone with Cushing's syndrome might have what is known as steroid diabetes because of that. Glucocorticoids, what do? They break down fat and proteins and increase glucose production. That's how they raise the blood glucose levels. So since there is protein breakdown, protein everywhere is broken down, these people, the skin is very, very thin. So their hair also becomes very thin, because remember, skin and hair have keratin, which is a protein. So their skin gets so thin that you can actually see on the abdomen, like a pregnant woman has those lines which are known as striae. You see in such people, you'll find abdominal striae present, okay? Here, the fat distribution gets a bit strange. Fat tends to be distributed along the center of the body, so centripetal fat distribution, and along the periphery, the fat is broken down. So they often have a face which looks moon face. So they look chubby cheeks, moon face, absolutely round. Okay? They also, because I said fat is distributed in the center of the body, not at the periphery, at the back, on the neck, at the back of the neck, because of distribution of fat. So if you look from the side, and I'll show you a picture, they have a little sort of pad of fat on the back which looks like a buffalo hump. Okay? And because of this, the center looking fat and the periphery, the arms and the legs looking real thin, they look like a lemon on a toothpick. So that's what these people look like. Okay? They also, this could affect a little bit of the zona reticularis, so, increase androgen production. Such people also have hirsutism. So now do you see that woman's face that I showed you, who had a moon face? I said she started putting on weight around her face, right? And she, she was hirsute, that young girl. But along with that, like you all told me, because she had increased sensitivity to cold, so the problem you can see was not in the adrenal cortex only, it was the possible pituitary tumor, like you pointed out. And that was primarily affecting the ACTH production, but it may have also affected the TSH production, which is why, maybe TSH levels became low, and that's why she was, sensitive to cold. So can you see that? So this is very typical of Cushing's: moon face, buffalo hump, lemon on a toothpick appearance. They tend to get very hirsute, very, very thin skin, straggly hair because of protein depletion. And then because the skin is so thin that and it's stretched in the abdomen, so they have these striae, abdominal striae. Another condition where you have just mineralocorticoids being affected, and this is hypersecretion, is known as aldosteronism. So here it would be the opposite. So increased sodium reabsorption along with water, so your blood volume will go up, so you end up having hypertension and edema. Then you may have a condition where the zona reticularis is affected. So this is hypersecretion in that area, based on whether it is a female or a male. So you have, if it's a female, then more androgens get produced in that area, so she looks more virile. So she, that's almost masculinization of a female. And if it's a man, it would be feminization. So, may develop breast tissue, so that's called gynecomastia, so the opposite effects. And a woman, she would develop a lot of facial hair and things like that. And then lastly, we have another condition where now the adrenal medulla is affected, and this condition is known as pheochromocytoma. So increased production of those catecholamines, and these people have hypertension because of, remember what catecholamines do, they increase heart rate, cause vasoconstriction, so they'll increase blood pressure, right? So these people, one of the predominating symptoms in pheochromocytoma is the patient will come with hypertension and then increased sweating as well, because, remember the sympathetic nervous system supplies the sweat glands. So here's a condition of Cushing's syndrome. So notice her around the central area, she's fat, she's got this buffalo hump, fat in the abdomen. The face is turned, but chubby face, which is what the case that I gave you. I said like she had a moon face, but she also put on weight around the abdomen. I don't know if you can see, but you can see this area, you can see these lines. This is where those abdominal striae, which are very, very typical because the skin becomes very thin. Hair also extremely thin. They have poor wound healing, these people, because immune system is depressed, right? So the wounds don't heal much. Also because glucose levels go up, remember? So then that becomes, whenever glucose levels go up, it's a nice medium for bacteria to thrive or even fungi to thrive. So people with diabetes as well have very poor wound healing. They can also have hypertension because remember steroids make the receptors more sensitive to catecholamines. So therefore a person with Cushing's could also have hypertension. So let's look at this Cushing's disease described.
Sometimes we're concerned about the body making extra steroids. That term is called Cushing's disease. What is that?
Dr. Caldwell, many times people come to me and are concerned that their child may be gaining weight because they may have a condition where their body is producing too much cortisol. Cortisol is produced in a triangular-shaped gland called the adrenal gland, and it's important in its life-saving mechanism of preventing stress from affecting the body. This cortisol is produced in very, very discrete amounts by the adrenal gland under a very sophisticated method of control. It is exceedingly rare to have a condition where the body makes excess cortisol, and one of the easiest ways that a primary care doctor can make sure that that's not happening is to ensure that the child's growth is normal. Should the child be growing abnormally, that means not growing tall enough, then certainly that could be a condition where excess cortisol is made. However, rarely there is a condition where excess cortisol is being made and a child would seem to be gaining weight out of proportion to what they should be, and at the same time not growing well. In this situation, it's oftentimes found a tumor in the adrenal gland or a tumor in the brain causing the adrenal gland to make too much cortisol. And this is best treated through a surgical approach with consultation with a neurosurgeon.
You can understand why they're not growing, because there's protein and fat depletion. See, protein is needed for growth, but if you're depleting the protein and fat, you're not going to be able to grow. Yeah.
This is a disease of the endocrine system. Why did they say you need to speak with a neurosurgeon or for surgery?
Because if it's a pituitary tumor, the neurosurgeon, you have to go through the mouth to and remove the adenoma from the pituitary gland. That's why. An endocrinologist and neurosurgeon work together. The surgery is done by the neurosurgeon. Okay, let's see here. Let's review this. Murphy suffers from a pheochromocytoma. Which of the following signs would you see in him? Hypertension, yes, not increased absorption of water because epinephrine, norepinephrine don't have anything to do with water absorption. Goiter is because of lack of iodine most of the time, and that's to do with the thyroid. Let's look at the next gland, the pancreas, and we'll be doing the pancreas again when we do the digestive system. So this is both an exocrine and endocrine gland. So right now we are looking at the endocrine portion. And when you look at the pancreas, this is an organ. We often call it a retort-shaped organ. You know, the chemistry, those of you who've done chemistry, there's glassware called like a retort, which looks like this. You ever seen something like this, a retort? Okay, so that's what it looks like. Present on the posterior abdominal wall, so it's right plastered on the posterior abdominal wall, lies in the C of the duodenum. This part of the small intestine looks like a C, so it's the C of the duodenum. Because it's so far back, and you have the other parts of the small intestine and the mesentery, which we'll do when we do digestive anatomy sitting on top. Tumors of this gland get very, especially cancerous tumors, are diagnosed very late, which is why you may have heard that prognosis of pancreatic cancer is very poor, because by the time you diagnose it, because it's so far back that by the time it really produces symptoms, it's far gone, that, you know, people usually die within 6 months of diagnosing. So if you look at the pancreas, it has different parts to it. This part is called the head of the pancreas. This area here, this part, is the head of the pancreas, followed by a narrow region which is the neck. This is the body of the pancreas, and this part here is called the tail of the pancreas, which is next to the spleen. This organ here is the spleen. In the spleen, you have the endocrine, most of the endocrine portion of the pancreas is located in the tail, and the endocrine part is where you have cells present. So they are these cells which are kind of clustered together as little islands. So this endocrine portion is often called the islets of Langerhans. So you have many groups of these islands which are called islets of Langerhans. These islets are present in the tail of the pancreas. Many different types of cells, but we'll concentrate on two major ones. Alpha cells in the islet, so some of these cells are alpha. In a normal light microscope, you cannot differentiate between them. These islets produce, the alpha cells produce a hormone called glucagon, and the beta cells produce a hormone called insulin. These two have antagonistic actions, okay? So let's look and see how both of these hormones are responsible for glucose metabolism, and they act hand in hand throughout the day. Now, we have an early morning class, so you've obviously had breakfast and come to class. So you've eaten food that's gone into your digestive tract. It's absorbed from the digestive tract, so your blood glucose levels rise. And this is sensed by the pancreas. So that glucose which you eat is meant for the cells. So what do you want to do? You want to take that glucose and push it inside the cells, right? So the pancreas first sense this increased level of glucose in the blood. They stimulate, the beta cells get stimulated and insulin is released. What insulin does is, it is very, very important to get the glucose from the blood and push it into the cells. So it increases the glucose uptake by the cells. So the end result is the blood glucose comes down, it comes to normal levels. So the function of insulin, therefore, you can see, is to decrease blood glucose levels. So it will do everything in its power to make sure blood glucose levels don't rise, okay? So one major thing it does is pushes the glucose from the blood into the cells. The other thing it does is, obviously, you don't eat just enough for your cells. You eat more than, what your cells need. All of that extra glucose goes into the liver and the skeletal muscle, where it is converted to glycogen. So you can see that excess glucose is not allowed to remain in the blood. This glycogen is stored in your liver and skeletal muscle so that your body can call upon it at times where you have less blood glucose, okay? So you have eaten breakfast, your insulin is acting, and your blood glucose comes to normal. Let's say you have a class and you go without lunch, and maybe you have another class it's happened quite often. You go without a snack in between, your blood glucose levels fall. Most of you do not pass out, right? You still can carry on your daily functions. And that's because when your blood glucose levels fall, the pancreas sense that as well. They then, in the pancreas, the alpha cells then get stimulated and they release glucagon. What glucagon does is it increases blood glucose levels. So what it will do is it will stimulate that stored glycogen in your body. So glycogen is broken down and made into glucose. That glucose is now pushed into your bloodstream, right? So your blood glucose levels will start rising, which will then stimulate insulin, and then insulin will be able to push that glucose into your cells. So can you see how both of them kind of act hand in hand to make sure your blood glucose levels are always kept normal? So here let's look at some of the functions. It lowers blood glucose, and it does this by making sure the uptake pushes the glucose into the cells, and then in the cells that glucose is utilized, it's broken down into ATP and carbon dioxide and water. It inhibits breakdown of glycogen. Instead, it causes storage of glycogen. So glycogen manufactures glycogen. So prevents breakdown, but instead make sure that glucose is actually, excess glucose is converted into glycogen. Remember, we used this term gluconeogenesis. That was glucose from non-carbohydrate sources. This was something where amino acids and fats were broken down to produce glucose. That was the definition of gluconeogenesis. Now you want to prevent that, right? Insulin would want to prevent that, because if amino acids and fats were broken down into glucose, what will happen? Your blood glucose levels will rise. Instead, what it does is it prevents this. Instead, it causes protein and fat synthesis. So it promotes proteins and fats. Instead of breaking them down into making more glucose, whatever excess glucose you eat is made into glycogen. If some more is left, it actually, from that, it causes fat and protein synthesis, which is why we say that if you eat a lot of carbohydrates, you tend to put on weight, because any excess that you have, insulin will make sure it goes and gets stored as fat. Okay? Most of your cells in the body need insulin for entry of glucose into them. If insulin is not present, glucose cannot enter the cells. Okay? Some areas of the body, like the brain, kidney and liver, they don't need insulin for glucose entry. Glucose can enter into them rather well, which is just as good for us in the brain. It can, glucose can enter. Though insulin is needed by the brain for normal brain development, memory, learning and all of that, but for entry into brain cells, into the neurons, insulin is not needed. Glucagon acts exactly the opposite. It raises blood glucose levels. So it will do everything in its power to make sure that glucose levels rise. It does this by breaking down glycogen. So these words we will be using again in digestion. So it's a good idea to kind of understand them here. So glycogenolysis. So what do you think glycogenolysis would mean? Breakdown of glycogen. So you can see glycogen and lysis of them. So if glycogen is broken down, it will give rise to glucose, because glycogen is formed by glucose molecules attaching to each other. So you break it down to its component parts, which is glucose. Glucagon will cause gluconeogenesis. So amino acids and fats are utilized for manufacture of glucose, and then that glucose will go into the bloodstream. So can you see it's doing exactly the opposite of insulin? You see that? Okay. Insulin prevents gluconeogenesis. Glucagon causes gluconeogenesis because it wants to raise glucose levels in the blood. So it does it by breaking down glycogen and making glucose from non-carbohydrate sources, which is amino acids and fats. Okay. So here let's take a look at insulin.
Hi, this is Mark from the MSOE Center for Biomolecular Modeling. The following animation will show the molecular mechanism whereby insulin triggers the uptake of glucose from your bloodstream. Soon after after a meal, the digestive system begins to break down the food you have eaten. The carbohydrates in this food are broken down into a simple sugar called glucose. As this glucose is absorbed from your digestive system into your bloodstream, your blood sugar levels increase. Your circulatory system then carries the glucose to muscle cells throughout your body, where it is used to generate energy. And here's the important part. In order to get that glucose that's now in your bloodstream into your muscle cells, you need to have insulin present to trigger that uptake event. Insulin is a small protein hormone produced by your pancreas. As the concentration of glucose in your bloodstream rises, your pancreas senses this increase and is stimulated to release insulin into the bloodstream. The newly released insulin plays a key role in regulating the concentration of glucose in your blood, a process known as glucose homeostasis. The insulin that is now released into your bloodstream binds to the extracellular domain of receptor proteins found on the surface of liver, muscle, and fat cells. This binding triggers the autophosphorylation of the intracellular domains, which, in turn, phosphorylate a specific substrate signaling protein. This protein then phosphorylates other downhill signaling proteins, leading to an amplification of the signal at each step. This overall signaling process is known as a signal transduction cascade. One important consequence of this signal cascade is the movement of glucose transport protein.
So the earlier part you can forget that, this detailed biochemistry, but now I really want you to watch this part and see how exactly it helps.
Called glues towards the cell surface. As these storage vesicles fuse with the cell membrane, the number of glues present on the surface of the cells increase, allowing the glucose to enter the cell. As a result, the glucose concentration in the bloodstream decreases. The glucose is now inside the cell, where it can be metabolized to generate the energy in the form of ATP that is needed in all of your cells. And that is how insulin helps the sugar you eat turn into the muscle that you use.
So you can see how, it's a very complicated process, but it makes sure that you have these transport proteins come on the surface so that glucose can enter inside. So you can understand if you don't have insulin, that will not be present. So even you may have a lot of glucose on the outside, but it cannot enter the cell. It's like water everywhere, but not a drop to drink, So let's look at some clinical conditions to do with this. So this is diabetes mellitus. So when we loosely use the term diabetes, we are always talking about diabetes mellitus. But remember, we have another kind of diabetes that you know of, which is called diabetes insipidus, which was to do with lack of ADH. So there are two types of diabetes mellitus, type 1 and type 2, and this might be a good way for you to remember. Type 1 used to be called juvenile diabetes because it's seen in young people. And type 2 was called adult onset diabetes, adult onset because it's in older people. Now, this has kind of become the very strict guidelines that they had, earlier on they said type 1 was only seen in young people, type 2 only seen in adults, but now that line is kind of become a bit blurry. You can see either or in either or people. So type 1 though is autoimmune. So here the beta cells are destroyed. So there is no insulin production at all, okay? Instead, now the body still needs ATP. Right? So what happens is that the body utilizes fat to produce ATP because fat and proteins can also produce ATP apart from glucose. Glucose is the first source that the body uses for production of ATP, but if it cannot utilize glucose because glucose cannot enter into the cell since there's no insulin, fat and proteins can enter the cell. It will utilize those. So when fats are mobilized, you produce something called fatty acids and glycerol. Fatty acids it's an acid, they lead to the formation of what is known as ketone bodies, and hence while you get ATP, at the same time your pH of blood becomes extremely acidic because of this ketone body. So you have something known as ketoacidosis. So anyone with type 1 diabetes, which is uncontrolled, if they do not control the type 1 diabetes, they will end up with ketoacidosis, and if your body pH falls, what will happen? You'll start breathing more rapidly because you want to get rid of that excess carbon dioxide being formed. Type 2 diabetes, and you can understand these people, what do you think their treatment would be? You have to give them insulin. They're not producing any insulin at all, so you have to give them insulin shots, right? Type 2 diabetes is a condition where either the body is producing very little insulin, so there is deficient insulin production, or the body kind of is resistant to whatever insulin is produced. So with the result that the effects of insulin cannot be, are not carried out to their fullest extent. So that's why there's deficient effects of insulin. Whatever the situation is, the blood glucose levels rise in both type 1 and type 2 because glucose cannot enter into the cells, okay? As that glucose is filtered from the kidneys, what will happen is that in the urine, you'll have excess glucose in the urine. So people, when you test their urine for glucose, you'll find glucose in the urine. Normally, all of us, when we take whatever glucose inside, when it's filtered through the kidneys, because our blood glucose levels are normal, as that glucose is filtered from the kidney, the body reabsorbs all of it and pushes it back into the bloodstream because we have enough transporters to carry that back into the bloodstream. In someone with diabetes, because the blood glucose levels are high, and that is known as hyperglycemia, as it is filtered from the kidneys, the body tries to reabsorb as much as it can, but there is so much that it has to pass some of it in the urine. That's why you find sugar in the urine or glucose in the urine, which is why it makes the urine sweet, which is why you call it diabetes mellitus. Now, glucose is osmotically active. Because it is present in the lumen of the kidney tubules and it's being passed out in the urine, it drags water with it. So when water goes out with it, you pass a lot of urine. Okay, so that passing lot of urine is called polyuria. Because you're passing a lot of urine, you can tend to get dehydrated. So you feel thirsty. See, because you have that symptom of dehydration. That's why you have, a person has symptoms of polydipsia. Dipsia meaning wanting to drink more. So a person has polydipsia. People with diabetes are always hungry because their cells, even though you have a lot of glucose in the blood, the cells are not getting glucose. So as far as the cells are concerned, they are starved. Okay? It's like if I put you in the middle of a sea and did not give you any water to drink. You have water everywhere, but you can't drink. So you feel very, very thirsty. So because their cells are starved, the brain realizes that, so it's always telling you to eat more. So these people tend to be extremely hungry, so increased appetite, and they eat more, and that's what is called polyphagia, so wanting to eat more. Okay, you had a question?
When you're younger, they tell you not to eat a lot of sugars and stuff, and then you become because you can become a type 2 diabetic. Why does it go the opposite? You understand what I'm saying? Like, you're taking in a lot of glucose, and then you become glucose deficient as you become an adult. You understand what I'm asking?
Can I suggest an answer?
Okay, go ahead, answer her.
Wear down of the endocrine gland that's overproducing insulin its whole life, it would wear down by older age, it's going to be more tired. Your body only lives so long, your heart only pumps, so many pumps per life, and you can only produce so much. Your cells can only split so many times before it can't split anymore. Scientific theory I read, but
Right.
I think my understanding of what your question is that it would wear the gland down, and it's not going to work as well. The more you use a car, the more you got to get it maintained to keep it up, you know. So if you're not eating properly in your youth, you're not going to give your body the nutrition to properly maintain itself in adulthood.
Exactly. That's the reason. They tell you not to eat so much sugar because you don't want to tax your glands to be producing so much insulin. Because all the sugar you're eating, your insulin has to take care of it. So the more you tax it, later in life, the more it's going to kind of give up after some time. Okay, so that's the reason. So let's take a look here at diabetes.
Finding out you have diabetes can be scary, but don't panic. People with diabetes can live long, healthy lives. Sure, let's go over some basics. This is diabetes. Made simple. When we eat, food travels to the stomach. Food is made up of 3 basic nutrients: carbohydrates, proteins, and fats. During digestion, carbohydrates are broken down into sugar, otherwise known as glucose. Here's a quick fact. Carbohydrates include foods such as bread, rice, pasta, potatoes, fruit, milk, and yogurt. In a normal digestive process, sugar travels from the stomach, through the bloodstream, to your body's muscle and fat cells. However, sugar can't enter these cells without the help of a special hormone called insulin, which is produced by the pancreas. Insulin acts like a key, unlocking the doors to the muscle and fat cells and allowing the sugar to enter. The cells then use the sugar as fuel to provide energy for the body. When this process is functioning properly, sugar entering the bloodstream from the stomach is able to exit the bloodstream at the muscle and fat cells. In this manner, the body is able to regulate the concentration of sugar in the bloodstream. Now let's see what happens in a person with diabetes. Sugar enters the bloodstream, but one of 2 things happens. Either the pancreas does not produce a sufficient quantity of insulin to match the sugar entering the bloodstream, or the body cells do not respond to the insulin that the body is producing. In both cases, the result is the same. Cell doors remain closed, causing sugar to get backed up in the bloodstream. As a result, blood sugar levels rise. This creates several problems. Because sugars are not able to enter your body's cells, your body is not getting the fuel it needs. As a result, you may feel tired or fatigued. Your body may try to dilute the excess sugar in the bloodstream by pulling fluid out of your cells. This can leave you feeling dehydrated and thirsty. Most importantly, over time, exposure to high blood sugar levels can cause damage to vital organs connected to the bloodstream, such as your eyes, kidneys, nerves, and heart. If not controlled properly, diabetes can lead to serious complications, such as blindness, amputation, kidney failure, heart attack, and stroke. In order to avoid these complications, people with diabetes must take steps to keep their blood sugar levels in a normal range. One way to do this is through diet. By reducing the amount of carbohydrates you eat in a single meal or snack, you can regulate the amount of sugar entering the bloodstream and prevent your body's insulin supply from becoming overwhelmed. This may mean limiting high-sugar foods such as cake, pie, candy, and soda. You know which ones. Another way to regulate blood sugar is through exercise. Physical activity makes your body's muscle and fat cells more receptive to insulin. In other words, those muscle and fat cells that wouldn't open before, now they will. Finally, your doctor may prescribe oral medications to increase your supply of insulin, regulate the amount of sugar entering the bloodstream, or make your body's cells more receptive to the insulin your body is producing. In some cases, insulin shots may also be necessary. Okay, let's review. We've talked about what diabetes is, a condition where either the body does not produce enough insulin, or the body's cells are not receptive to the insulin being produced. We've seen what complications can arise from it, such as fatigue, dehydration, and damage to vital organs. Finally, we've discussed ways to manage it through diet, exercise, and medication. For more information about your specific health diagnosis and treatment,
and diabetes affects almost every organ of the body. And the reason is because this high blood glucose levels causes microvascular changes. So when the blood vessels are affected, for example, in the eyes, it causes blindness because the retinal blood vessels are affected, so it can cause problems there. It can cause cataracts because, again, the high sugar in the blood affects the lining of the lens. You get diabetic neuropathy. You may have heard of that when people become insensitive to pain. But again, it causes microvascular changes in nerves as well as blood vessels. And the parts furthest away from your heart get affected first, which is why the fingers and toes get affected more. So when you can't feel sensations, if you touch anything hot or something, you can damage it. You're not feeling that. There's high glucose in that area. That is, like I said, a good medium for growth of bacteria and fungi, which is why these people have poor wound healing. The blood supply is not good, plus infection becomes more common. So that's why you can see how everything is affected and why it's so important to kind of catch it fast and take care of it. You had a question?
Yeah. When we're talking about sugars here, are we talking about natural sugars and like sugars from like sweets, or are we talking about just sugars?
You're talking about carbohydrates in any form.
Okay, so even like fruit and stuff?
Yes, yes, fructose, yeah. Fruits, there are some which are very more rich in fructose, so you have to kind of avoid those. Because anyway, it goes into the body and still forms glucose. So you have to be very careful about your diet. I mean, someone who's diabetic cannot eat a whole bunch of bananas. Okay, let's see this. Let's answer this question. You would expect patients of type 1 diabetes to be? Okay. The correct answer is all of the above. Well, we do know it produces ketone bodies, right? They were produced because of excessive fat breakdown. And even protein is broken down because glucose can't. And that's why these people with type 1 diabetes usually tend to be extremely lean. They're very thin because fat is constantly being broken down as well as protein. So they are extremely lean. Because fat is broken down and fatty acids are produced which lead to ketone bodies, those fatty acids also get deposited. There's an increased fat circulating in the bloodstream, get deposited in arteries and lead to plaque formation. So they also at a young age suffer from atherosclerosis. So all three actually happen in type 1 diabetics.
Is there one that's better than the other?
I doubt. I don't know whether we would choose one or the other.
In the video it said oral medication?
Yes, oral, and they are called oral anti-diabetic drugs, which are given in type 2 diabetics, where not in type 1. You give it in type 2 diabetics to increase the production of insulin or make the body more sensitive to whatever. Yeah. And the last gland is pineal gland. It's part of a portion of the brain called the diencephalon, which includes the hypothalamus as well. And this produces a hormone called melatonin. Do not confuse this with melanin, which is a pigment in the skin. This is melatonin. It is important for maintaining your sleep-wake cycle because of the way it is produced. You know, darkness causes melatonin production, which is why you go to sleep at night. Daylight or light prevents release of melatonin, and that's why you stay awake. So that's why it keeps this rhythm going, the circadian rhythm, or what's called the diurnal rhythm. You had a question?
Where is serotonin?
Serotonin is produced in many areas of the brain. A lot of it produced in parts of the diencephalon, in areas called the limbic system. So it's kind of like a feel-good hormone. So there's not just one area of the body where serotonin is produced. Produced in many areas of the brain. Like dopamine. Both dopamine and serotonin together, yeah.
So is serotonin, it is a hormone?
It is a hormone. It's a neurotransmitter, not yeah.
Oh, so it's not, okay.
No, not a hormone. In the brain, a lot of these substances which are produced act as neurotransmitters because they allow passage of impulses. In some parts, the same neurotransmitters are hormones like epinephrine and norepinephrine produced in the adrenal medulla. You get that? But you have epinephrine and norepinephrine produced in the sympathetic part of the nervous system where it's a neurotransmitter. But in the adrenal medulla, it becomes a hormone.
So it just depends on
where it is produced. Yeah, the actions still remain the same.
Oh, okay.
Yeah.
Okay.
Yeah.
Now, like a person who has insomnia, would they have decreased levels of
Could be. They could have decreased levels of melatonin. Insomnia is such a wide spectrum. It could be anything. And one of the treatments actually they say for insomnia is that they ask the person that go out in the daylight and make sure that your eyes are exposed to the sun so that you decrease melatonin secretion during the day, and then at night they tell you, which is why they tell you if you have difficulty falling asleep, make sure that everything is covered. You do not have any light in the room where you're sleeping. Even a little bit of light will affect melatonin secretion. Then they also tell you that make sure you're not exposed to blue light, which comes from the TV and the computer and all that, at least a couple of hours before you go to sleep. Yeah. Insomnia, it's not like you take melatonin, you'll always, but it does help.
I've, watched enough TV where I've seen these commercials for this NOM24 that I guess happens in a lot of blind people who are born blind. And have you heard about this? These
No.
people that have terrible insomnia and can't sleep, and because they're blind, they don't know whether it's day or night.
Right.
And they've done, they're kind of doing studies saying, okay, even if they can't, they're doing light therapy on these people that somehow is affecting, even though they can't see it, it is helping them sleep at night. You heard anything about
No, unfortunately I don't. No. It could be that they're giving them light therapy so that, melatonin is depressed, and then at the time when it's night, so the body can differentiate between, okay, now it's depressed and now there's no light, so now it can be secreted. So maybe they're kind of making sure that this rhythm is maintained, which we'll see here if you look at this picture. So more is produced during dark periods. So if you look here in daylight, from the retina is exposed to more impulses, and this goes to the hypothalamus. There's a place called the suprachiasmatic nucleus in the hypothalamus, from where it goes to the sympathetic nervous system. The impulses are carried there, and this goes to the pineal gland. So during light, norepinephrine, which is secreted by the sympathetic, and here it's a neurotransmitter, it inhibits melatonin secretion. So you have lack of sleepiness and you're alert. During night, when there is less light, the retina sends fewer impulses to the suprachiasmatic nucleus, fewer impulses go to the sympathetic nervous system, so fewer will come to the pineal gland, so it kind of is brought out of that inhibitory effect. Now lack of norepinephrine means melatonin secretion can be increased, and that causes sleepiness. So that's how you can see that absence or presence of light, how it affects that. That's usually who fall asleep. There is a condition known as narcolepsy, where people who are sleepy all the time, and that's possibly some neurotransmitter problem going on there. But otherwise, when you sleep in class, it's just tired. You're just tired, or bored, or both. Yes. What? Which one? Shift disorder? Worship? Oh, work shift. Oh, those who do the graveyard shift, are you talking about that? Their body adjusts. And your body adjusts to a lot of things. What is happening here is, for all of us who have regular working hours, somebody doing the graveyard shift who's working late at night, they have to keep awake, and their body kind of adjusts to that. Even people who work at bars and things like that, stay awake late, they're awake all the time, and then they come back home, and so their rhythm is actually switched. So what is night for us is day for them, and vice versa. So the body just adjusts your rhythm. Okay. Yeah. Oh, the body can adjust. Of course, it can. Yeah.
Okay. This is being recorded because I need to show somebody what you just said.
Okay.
I argued with my ex the whole time. He told me that no, your body can't switch. You're natural this way. There's only one way the body works. Like, I was born nocturnal. I'm telling you, my mom raised me nocturnal. I'm awake at night. I sleep during the day. And we fought all the time about it. So I'm going to show him this video.
Yeah.
Thank you.
It also, apart from the body shifting, during different phases in your life, also you go through these. As a child, for example, you sleep all the time. And little children are supposed to sleep because a lot of growth hormone is produced during sleep, which is why it's good for babies to sleep. Then, when I was growing up, for example, my mom would tell me, lights off, 8 o'clock. And as a teen, I just had to have the lights off, and I was wide awake. I just couldn't sleep. Well, there wasn't all that much study those days about teen brains. Teen brains are very, very different. But now we know that teenagers are pretty nocturnal. They cannot sleep early. It's just a way the brain is kind of adjusting. Teenagers sleep late, which is why they wake up late. And a lot of, in fact, they say even 15 minutes of that morning sleep makes a big difference for them. So at one point, like in Pinellas County, they were suggesting that, here are two high schoolers agreeing with me, I think, right? Yeah. They said, it's strange that the earliest route for buses is for high school students, right, who actually like to sleep late. But they said that, they wanted to kind of extend the time. So if school was starting at 7, they wanted to make it at 7:15, because they said that even that 15 minutes makes a big difference, because high schoolers tend to sleep through the first period, right? Because of this fact like this. But then the reason they didn't switch it is because a lot of high school students have jobs, so they'd much rather they don't mind sleeping through the first 2 periods and then go to their job. So your body does keep adjusting throughout life. And then, as we get a bit beyond adolescence, then we come to this normal kind of thing. And then when we get older, again, your sleep patterns change. So, your brain adjusts all throughout life. No, don't get upset. Don't get upset. No, don't get upset if he wants to stay awake late. I mean, I had to do that. Let them sleep late. In fact, even for everything, brain development, I don't know whether it was this class or some other class I taught, the prefrontal lobe, this part of the brain, actually matures by around 21 years of age. This is the area of the brain that's responsible for judgment and intellect and decision making. Teenagers don't make wise decisions because that part of the brain hasn't yet developed. You go fast, you drive fast. They do all of these crazy things because they still haven't formed that thing yet. And this myelination of the brain tends to occur from the back to the front. So which is the last area to get myelinated? Prefrontal cortex, okay? So when they say teenagers, what were you thinking? They really weren't thinking, because they haven't developed the ability as yet to think, okay? I know, yes. I haven't, this is not something I said in front of my kids at that time.
Everything I'm hating myself for.
Okay, let's see. What do you think of this? Is the secretion of melatonin increased in winter? Yes, very good. Winter, longer nights, shorter days, gets dark early, so you tend to feel a bit more sleepy in winter. Okay, let's look at this question. Now, remember I said you should learn the hormones. There are groups which act on a certain thing. You should learn them as groups. Now, which of these is not a hormone pair based on antagonistic action? Yes, very good. It's growth hormone and thyroxine. Some of their effects are very similar, act on the musculoskeletal system, both of them. Parathormone and calcitonin on calcium metabolism. Parathormone increases serum calcium, calcitonin decreases it. Insulin, glucagon, and glucose metabolism. Insulin decreases, glucagon increases. ADH, ANP on water reabsorption and blood volume. ADH increases water reabsorption by kidney tubules, increases blood volume. ANP decreases sodium and water reabsorption, pushes water out of the body, so decreases blood volume. So these three are antagonistic, these three pairs. This one isn't.